Thank you so much. I really appreciate you being here and coming to join us after school and sharing your experiences and about yourself with us. We'll pass it on to Dr. Oussama Abla to share a little bit more about JXG.
Good afternoon. And first of all, Michelle, your story made me almost cry. I can't imagine what you went through. And I'm happy that in the end, we can see Ty in person growing and that he's done very well. And on behalf of my colleagues who in the beginning could not understand why or what he had, I apologize on behalf of them. Nate, I'm really bad at sharing, so I apologize. My kids laugh at me all the time. So I'll try to share, but if I'm not able, I did send you my slides. So
okay.
Did you receive them?
Yes.
I'll try to share from my end. So give me so that we don't lose too much time.
Oh, you got it.
Can you see my slides?
Perfectly, yes.
Okay. So, well, first of all, thank you for inviting me, and I'm really happy to be here. And again, I will never forget Michelle's story, from which I learned a lot today. So, before digging into JXG, I'm sure this introduction to the non-LCH histiocytosis was already mentioned today. But what we're dealing with is here basically the accumulation and the proliferation of these abnormal non-LCH cells in many affected tissues. But JXG, differently from LCH, it has a wide spectrum of differently or even similar. It can be self-resolving, unifocal, but can also be disseminated and life-threatening forms. But it's also more diverse than LCH. There are so many forms of JXG that I will explain later. So historically, it was considered to be just a bad inflammation, granulomas. Now we consider it a type of myeloid neoplasia or blood cancer. And in 2016, we and others from the Histiocytic Society, we proposed a new classification of the histiocytic disorders, and we divided them in 5 groups. L group, L stands from LCH, the C group for cutaneous, R group from Rosai-Dorfman, M group, malignant histiocytosis, H group or HLH. So JXG fits a little bit between in the L and the C group. L group because of the presence of MAPK mutations at the origin of the initiating event, and the C because there is a lot of, most of the JXG are cutaneous. So as Michelle said, it's the most common non-LCH disorder, as I said today, considered a myeloid neoplasm. And the origin is not a dendritic cell, it's a skin macrophage. It's quite rare, 1 case per million per children per year. However, I do have to say that this is an underestimate. Many cases of JXG get not diagnosed, whether they are in the skin or whether they are systemic. The median age is about 2 years, usually for solitary skin cases. Boys are more affected than girls. And there's a strong association with a type of leukemia called JMML, or juvenile myelomonocytic leukemia. And I won't go into that. It's extremely rare type of leukemia in children and infants. But the risk actually of JMML increases 32 times when someone with JXG also has NF1 or neurofibromatosis 1. And I've seen in my practice at Sick Kids, which is the largest pediatric hospital in Canada, I've seen only 1 case of JXG with NF1, and so far he did not develop JMML, and he's past the age where JMML can happen. As we know, skin is the most common presentation, but up to 10% can be systemic. Systemic means an internal organ. And the outcome really depends on the extent of systemic disease, whether systemic in the body or in the brain or CNS, central nervous system. Well, how does it look like? So the skin one, which is the most common, can be just a regular, this node that is yellowish to orange, can be single or a few of them, can have this appearance here. But there are really bad forms where this is a progressive nodular histiocytosis, which is one of the subtypes in the JXG family. But when you have these kind of lesions, they tend to disappear spontaneously and fade over months and years. How does it look on pathology? So the LCA stains, CD1A and Langerhans are negative, but classically on the microscope, you can see these two-toned giant cells, histiocytes, and there's a few stains specific for them. One of them is CD68, which is positive, CD163, FASN stain, factor 13A, and so on. But there are some variability. Some diagnoses can be difficult. For example, early lesions may grow rapidly and they may have a high mitotic activity, means that they divide rapidly. They may lack these lipids within the cytoplasm, we call xanthomas, and they may lack two-tone giant cells. And some of them may have CD1A positive cells, but they're not really LCA, as in this case here. So this is still a really aggressive skin and subcutaneous JXG. What is the cause of JXG? Well, we don't actually know, but in recent years, we know that there are MAP kinase mutations in all the histiocytic neoplasms. So this, on the left side, you see the LCH1, and on the right side, you see the non-LCH1s. That includes JXG. Some of them can be BRAF positive, especially boys with central nervous system JXG. Some of them may have NRAS, KRAS, MAP2K1, RAF fusions, or ALK fusions, or NTRK1. And I'll talk about that at the end of my talk. Because again, JXG, we found out that it's so diverse at the clinical level and at the molecular level, it's very diverse. In fact, how many forms do we have? So we have what we call the JXG family and the JXG-like entities. JXG family, I've seen young kids with benign cephalic histiocytosis, with lesions of the skin that can affect only the face, the neck, and the upper shoulders. And this is an early form of JXG that resolves spontaneously. You can have a generalized eruptive histiocytosis, which can be present both in children and adults, like many areas in the body. And you can have what we call multicentric reticulohistiocytosis, more common in adults, but you can see it in children. Not only they have these lesions on the skin, but they also have arthritis, and they have systemic involvement. They present like rheumatoid arthritis, and you need to treat with actually chemotherapy. And then you have xanthoma disseminatum with these kind of lesions. They also have internal organ systemic involvement and other entities like progressive nodular histiocytosis and mucinous progressive histiocytosis, which I haven't seen in my practice, but it's very rare and can be hereditary. But not all skin lesions are present in LCH. In fact, we have, as you may have seen in other presentations before me, disseminated histiocytosis like in LCH of the child or the adult can have skin involvement. Erdheim-Chester disease of the adult can have that. I'm sure Dr. Eli Diamond showed some pictures. Rosai-Dorfman disease can have skin involvement. But again, going to JXG, you can have this kind of aggressive aspect on the face, head, and neck in both adults more commonly, but also children, that sometimes they can get better, even spontaneously, or I'm guessing this patient had some chemo, or sometimes they can progress over years and can be quite aggressive and cosmetically really not very nice looking. So it's more common in children, but in adults it has been described certainly, and it can usually present with single lesions of the head and the neck. Usually adults around 30 years, but it's been reported up to the age of 80 years. They don't really go away spontaneously in adults. You really need to do surgery for a skin JXG of the adult. The other problem is ocular or eye involvement, that patients may present with red eyes, uveitis or inflammation of the surface of the eye, glaucoma, or even retina or optic nerve involvement, and in very rare cases, blindness. This subtype happens in about 1% of cutaneous JXG, In 90% of the cases of ocular JXG that I've seen in practice and published, less than two are usually young children, less than the age of 2 years. So what we do for these patients, after the surgeons, after the ophthalmologist sends them to us, the patients who are really young, less than the age of 2, with multiple skin JXG, we send them to the eye doctors. And you really need to diagnose it early on because it's really important for the vision and the final outcome. How do we treat? Well, in my practice, usually surgery, surgical excision of the lesion, but people have given steroids in the lesion, a drug called bevacizumab, which is an anti-growth medication, laser, or even BRAF or MEK inhibitors in recent years. That can actually cause a rapid resolution or improvement, at least. But I've also seen young kids, infants, with deep soft tissue lesions. I've seen it on the thighs, in the knees, on the ankles. And funny enough, these patients, these lesions, they tend to resolve spontaneously if you just monitor them. I apologize. If you monitor them over time. But I've also seen central nervous system lesions, compressing them like these cases here. But the CNS lesions, they rarely resolve spontaneously, especially when they are multiple. So you need to do something about them. The systemic JXG, as Michelle said, 50%, they will not have any skin lesions. And the median age of onset usually 3 months. So it tends to be, from my experience and from what I hear from the literature, it tends to happen in young babies. They may have big liver and big spleen, jaundice, yellow eyes, and yellow of the skin. In the lungs, they may have multiple nodules. They may have mediastinal adenopathy. It can be involved in the bone marrow, so you have low blood counts. When it's involved in the central nervous system, in about 2% of the cases, patients present with either seizures, developmental delay. The speech is delayed, everything is delayed. It can affect the leptomeninges, so patients may present with seizures, headache, and they can be single or they can be multiple lesions. Spinal lesions have been reported, and as I mentioned, a series by Dr. McLean and Jen Pekarsik showed that many cases of CNS JXG tend to be BRAF positive, and it tends to be more common in boys. That's this subtype, specifically CNS. What's the prognosis? What's the evolution? So, as we know, for the skin and the soft tissue JXG, they tend to resolve over time, 100% survival. Rare cases of topical sirolimus have been given for multiple lesions of skin JXG, and rarely BRAF or MEK inhibitors have been given for aggressive skin JXG. So, but when it's the most common form, we just observe them, but we do see them in our histocytosis clinic. Why? Because we monitor them for a CBC, the blood counts, and we monitor the monocyte counts to monitor for the make sure that they don't develop JMML. Do we do that until the age of 18? No, because JMML onset usually is within the first 7 to 8 years of life. So at least until the age of 7 or 8, actually 8, we would do a CBC at least every 6 months just to monitor them. But then you have, on the other spectrum, the very sick patients, infants who have liver involvement, CNS involvement, bone marrow involvement, or a large retroperitoneal or even mediastinal JXG. For these patients, you need to treat for organ dysfunction because they can rapidly grow these cases and they can become disseminated and they can be life-threatening. So we give LCH-like therapy. Michelle mentioned vinblastine and prednisone. That is usually the first-line therapy for these cases. There is an older literature showing an overall mortality of 5 to 10% due to liver failure or CNS. More recent literature about 6%. Then there's a subtype of CNS JXG. What do we do for these cases? So if it's a localized lesion, one focal lesion, then my first approach is to suggest surgical resection if it's completely resectable. But if it's multifocal or really dural-based, you cannot do surgery, then people have given dexamethasone alone. We had one case many years ago who initially had LCA as a child, as a teenager, developed brain lesions. We thought it was LCH. We treated her as LCH. She wasn't responding. Then we ended up doing a biopsy, and she had actually developed a CNS JXG after LCH, many years after LCH. So we ended up giving her some chemo, cytarabine. Response was really slow. So we put her back on weekly vinblastine over a year, and her lesions slowly shrunk. And then at some point, we stopped the treatment and we repeated the MRI after 3 months, and the lesions were all gone. So, but for CNS lesions, cladribine and cytarabine, either alone or together, can be very effective. Clofarabine can be very effective. And rarely radiation therapy to the brain can be effective, although we like to not use it in young children because of the side effects and to also avoid long-term neurocognitive problems like learning problems and so on. But in reality, in recent years, since the discovery of mutations in the BRAF and the MAPK pathways, the most encouraging and the most dramatic and rapid responses that we've ever seen are really happening with inhibitors, BRAF and MEK inhibitors that have been used certainly for CNS JXG, ocular JXG, aggressive skin JXG. So, but it's not all rosy here. Like the fact that these drugs can cause rapid resolution or improvement is amazing. However, they do have side effects like skin problems, ocular problems, heart problems. They're not really curative. They just stunt the cell, and we don't know when to stop them. So this is a whole chapter of these inhibitors. We're not going to go through into that. But the other thing that I want to say for systemic JXG, the outcomes, basically. There's a recent systematic review of the literature. A Chinese group looked at 103 articles. They identified 159 patients with systemic JXG published between 1981 and 2022. Median onset of age was 9 months, predominantly males, as we mentioned. There were around 58.5% alive with no disease, 35.2% alive with disease, and 6.3% had died of disease at the last follow-up. Spleen was the most important predictor of high risk of death, and permanent long-term sequelae seemed to be mainly CNS symptoms, and in some cases, ocular late effects as well. Another paper looked at long-term outcomes in 20 children with extracutaneous, means systemic JXG from Japan. Median observation was 10 years. 15 out of 20 were treated. 11 of these 15 were treated with chemo. 17 were alive without disease. 2 alive with disease. 1 newborn died. Permanent sequelae that we see in these cases, central diabetes insipidus, which is an involvement of the pituitary gland where patients present with massive thirst and they pee a lot. They can regulate their fluid intake and output. So they need to be put on a hormonal replacement. Growth hormone deficiency and short stature, panhypopituitarism of the pituitary gland. So many deficits in the endocrine pathway, visual impairments, even late epilepsy, mental retardation, especially these last 3 in patients with brain lesions, but also some adverse effects from chemo like low blood counts, immunosuppression, and some organ toxicity. They found that the relapse rates were quite low, but refractory or persistent disease was more of an issue, and permanent sequelae, especially in the CNS, was also an issue. As I mentioned, there are new molecular JXC subtypes that we did not know in 2013. An entity called ALK-positive histiocytosis. Basically, on pathology, these are JXG. 30% of them have a JXG histology. Others will have a spindle-like cells, but they do the staining for the ALK on the immunohistochemistry. But you also need to detect the ALK fusion to confirm the diagnosis. This is a series where we also participated 3 years ago, a large number of patients. We were able to identify, 31 children and 8 adults and divide them into single system and multi-system. The multisystem disease, we have a group 1A, infants with liver and hematopoietic involvement, outcome not so good. And group 1B, other patients with multisystemic disease, 10 patients, 70% of these had CNS involvement, brain involvement. Group 2, 23 patients, 52% had isolated neural involvement, and others had non-neurologic involvement in isolation. Again, most of the patients were children, but there were adult patients as well. And what came out from this is that the ALK-positive histiocytosis, especially the CNS one, they tend to benefit from new drugs called ALK inhibitors. This is a patient at diagnosis with this mass here. This is after the lorlatinib. You can see the improvement. Same thing here, crizotinib before and after. So these drugs are amazingly effective, especially for the CNS, but also for systemic disease. Another recent rare entity is having this fusion here, MRC1 PGFR beta. This is a kid from Germany where they basically removed this lesion, and this tends to respond to dasatinib. Years ago, I was asked to review this paper from St. Jude. Also, dasatinib can induce dramatic responses. Dasatinib is another tyrosine kinase inhibitor. So again, not chemo, but inhibitors, oral inhibitors. And a more recently identified entity, NTRK1 rearranged histiocytosis. Basically, again, most of them would have skin involvement, as you can see from these pictures, on the eyelid, on the arms, and the breast tissue. But they can have systemic involvement. This kid had liver involvement, again, infant. Another one had kidney and bone involvement as well. Basically, they had found 50 cases, 30 children and 20 adults. Again, more commonly males, but almost 90% of them had limited skin disease, 12% systemic disease, some of them too with life-threatening. They all had JXG histology, and they stained positive for this gene here. I won't go through many details, but some of them were having bone marrow involvement. They were just treated with supportive care, like platelet transfusions. Some had surgery, and one had treatment with an TRK inhibitor with good effects. And others, they were just observed. The bottom line is that this fusion occurs predominantly in the isolated skinned JXG, but you may have severe extracutaneous lesions in very young children and infants. Overall, favorable clinical outcome, except in young patients with really bad systemic involvement. Targeted therapy is promising. There's a limitation is that this is a retrospective study, and again, a smaller number of cases. Overall, what are the take-home messages? Really, there are no large series for this niche. It's all retrospective case reports, small case series. It's the most frequent non-LCH of the children. In children, mostly is self-healing, but there are forms that can be multisystemic and can require a treatment and can be quite life-threatening. Today, any consult I receive by email of any type of histiocytosis, I always recommend a centralized pathology review by an expert pathologist, but also mainly to have samples sent for MAPK mutation analysis, either by a TrueSight or by NGS, because it will really be important for us to know. The ALK positive one had neurologic involvement, and they respond to ALK inhibitors. And NTRK also isolated skin can respond to inhibitors, and this fusion is quite rare. And my last slide is that since 2015, I've been running an international registry for rare histiocytic disorders. The aim was to collect retrospective and prospective look at the treatment and outcomes of these patients worldwide, understand their overlapping pathology, their biology, and their molecular features, and maybe also look at future treatment recommendations. We have so far enrolled, I didn't have time to add our data here, but we've enrolled 66 patients with JXG. Many of them were systemic and some were skin. And funny enough, we had one case who developed JXG after treatment for acute lymphoblastic leukemia. So you can have JXG as a secondary event after an acute leukemia, but it's quite rare. and those cases don't always do well. And thank you for your attention, and I'm happy to answer any questions.